So today we're diving into patient-reported outcome measures, PROMs, and whether clinimetric or psychometric approaches work better in clinical settings. Kinda niche, but very impactful, right?
Absolutely. It's that classic dilemma: psychometric elegance versus clinical utility. PROMs started off with psychometric roots, but turns out that might not always work well in actual patient care.
Right. Psychometrics likes everything neat and homogeneous, same type of questions measuring a single dimension. But do patients really think like that?
Not really. I mean, when someone's depressed, do they experience just one tidy symptom? Nope. It's messy, layered, fatigue, hopelessness, anxiety, all rolled into one.
And that's where Clinimetrics shines. It says, forget homogeneity. Let's talk sensitivity. Can this tool actually capture change in real life, not just give consistent results?
Exactly. Like, Cronbach's alpha is great for measuring internal consistency, but if all the questions basically ask the same thing, you're not getting anything new.
It's like asking, are you sad? Then are you blue? And do you feel down? All dressed up, but it's the same suit.
Haha, true. Clinimetrics flips that. It says, each item should add something distinct. You want questions that give you different windows into the patient's world.
And that's especially important in treatment, right? Because the change doesn't always show up in just one domain.
Totally. Psychometric scales can miss those subtle improvements or declines. A patient might be less anxious but more fatigued, and the right PROM needs to catch that.
Yeah, and retest reliability. Clinimetrics doesn't fuss as much over that. I mean, people change, especially in a clinical setting. So perfect reproducibility might be a red herring.
Yep. Clinimetrics values sensitivity to change over repeatability. It's like preferring a thermometer that catches fevers over one that just always says 37 degrees C.
I love that analogy. Also, let's talk validity. Psychometrics wants scales to match other validated ones, concurrent validity. But Clinimetrics wants clinical validity. Can this tool actually predict outcomes, guide decisions?
And that's the point. For example, if a PROM helps predict relapse or response to a specific therapy, that's gold. That's predictive validity in action.
Incremental validity too. If a new PROM adds something unique to what we already measure, it earns its place. No duplicates for the sake of psychometric perfection.
It's like you don't want 5 thermometers saying the same thing if one of them can also tell you when a patient might crash next week.
Haha, exactly. Also, Clinimetrics brings in something that psychometrics kinda ignores: sensibility. Is the tool actually easy to use in practice?
Right. A 50-question survey with 7-point Likert scales may be valid, but if no one uses it, what's the point?
Clinimetrics likes short, sharp tools. Think of the WHO-5, just 5 items, but clinically powerful. It even predicts mortality in cardiac patients.
Impressive, right? And then there's transferability. Does the PROM still work for different people, over time, in varied settings?
That's huge. That's a tool that only works in academic trials but falls apart in primary care, not helpful.
And that's why the article calls for a shift. The field's been obsessed with psychometric theory, but real-world care needs clinimetric logic.
So to wrap, PROMs aren't just about statistical neatness. They're about being sensitive, clinically valid, and actually useful.
Exactly. Maybe it's time we stop asking, is this PROM reliable? And start asking, is it actually helping the patient?
And with that, something to ponder until next time. Can your outcome measure really measure what matters?
Great question. Let's keep it real and clinimetric.